Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Come on in, Henry. How are you this morning?
Not too bad, thanks, Doctor. And yourself?
Oh well, busy as usual.
Yeah, I can see that. There are a lot of customers in the waiting room.
Yeah.
There was a nice spot of rain we got last night.
Yes, it certainly saved watering the garden, and that was a bonus. So, Henry, have you come for your blood test results?
Yeah, that's right. Give us the news, Doctor.
Well, it's not bad news, but your total cholesterol was 6.6, your triglycerides 1.6, and your HDL was 1.54, and the LDL was 4.65.
So what does that all mean, Doctor?
Well, you remember we did the same test a year ago?
Yeah.
So what these current results show now is that compared with last year's results, there has been a sharp rise in your LDL level.
Yes, well, what's brought this about?
Well, as we discussed last year, cholesterol is carried in the blood by different types of protein carriers called lipoproteins.
Yeah, I remember that.
Well, the two which carry the most cholesterol are the low-density lipoproteins, LDLs, which we believe promote atherosclerosis or thickening of the arteries, while high-density lipoproteins, HDLs, tend to prevent this. In your case, unfortunately, your LDL has increased, and there are a number of factors that may have contributed to the rise in your LDL. For instance, a higher fat content in your diet,
Right.
increase in stress,
Mm-hmm.
maybe you're not exercising as much as you were.
I guess I'm not.
That's right. Have you noticed any discomfort or had any general health issues that have caused you concern lately?
No, not really.
Okay, now Henry, I know your family history and that your dad died of a stroke at 60. I just want to ask you a few questions about what you're doing now.
Sure.
What about your current diet? Are you eating much fatty food?
Yeah, I guess so. I mean, I do enjoy McDonald's at lunchtime and eat quite a bit of meat. I'm not really a big fan of vegetables.
Yeah. Have you noticed any change in weight? Do you think you've gained a little?
Well, since I last saw you, I've probably put on about 5 kilograms.
Yeah, well, that's quite substantial. What about exercise? Do you still manage to do that regularly? I remember last time you told me that you were taking your dog for a run once or twice a week and that you swim regularly.
Well, actually, in the last year I've been pretty busy at work and I've had a lot of family commitments lately, so I'll probably exercise a bit less.
And are you still smoking?
Yes, I am. I mean, I've tried to cut down though. I'm probably smoking 5 or 10 cigarettes a day.
Okay. And how about alcohol? How many alcoholic drinks do you have in a week?
Well, in a week, I probably have 2 or 3 a day, so I don't know if you multiply that, I guess it adds up to quite a few, 16 or more maybe.
And would you say that you drink more at the weekend?
Yeah, a little bit more on the weekend. We have a glass of wine as well at night sometimes.
Right. Okay.
Extract 2. questions 13 to 24. You hear a physician talking to a new patient called Bernardito. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Good afternoon, doctor. I am Bernardito.
Good afternoon. May I know what your problem is?
I am having a severe stomach ache.
What do you feel?
I have heartburn and severe pain, doctor.
Since when have you been feeling this acidity and pain?
For the past 2 months, my stomach hurts after every meal. The pain persists even during nights.
Have you eaten any heavy food or something different in the last 2 months?
No, actually.
How severe is the pain? Let's say on a scale of 1 to 10, how would you scale the severity of the pain?
Well, I can say between 4 to 5.
Is the pain continuous?
No, it hurts only fleetingly.
Do you feel the pain after meals?
Yeah, probably, because it hurts every time after I eat.
Is there any kind of food that bothers you much?
Yeah, greasy food.
Oh, I see.
Yes, at home we eat a lot of greasy food.
Where in the abdomen does it hurt? Tell me the exact point. Does the pain shift to your chest, shoulder, back, or across your abdomen?
It hurts in the middle. At times the pain moves across my abdomen.
Besides the pain, you said you have heartburn?
Yes, I feel a kind of sour taste whenever I burp.
Do you feel like this more during the day or in the evenings?
Both. I feel the acidity during the day and at night.
Is it getting worse whenever you lie down?
Yeah, I get an acid-like taste in my mouth.
Besides greasy food, are you getting some irritation in your stomach when you eat any other kind of food, like spicy food?
No, actually, we don't eat spicy food at home.
And tell me, how frequently do you have a bowel movement?
No, it hasn't changed. It's regular.
And tell me, how frequently do you have a bowel movement? And has there been any change in your bowel movements for the past 2 months?
Yes, it has become a little bit softer.
Is there any change in the color?
Yeah, it is greener.
Greener and not darker? Any blood in your bowel movement, or is it darker?
Not darker. And there wasn't any blood in my bowel movement.
Okay, let's first diagnose your abdomen to check from where the pain comes. You said you are feeling pain at the middle part of your abdomen.
Correct.
Does the pain stay there only, or does it move somewhere else?
It usually stays there.
Do you feel acidity and heartburn during the pain?
Yeah, you were right.
Do you have vomiting or nausea?
No, not now.
What did you eat today?
I ate meat and tomato sauce.
Do tomatoes give you any trouble?
Not exactly. I have been eating tomato sauce always.
Do you get any trouble when you have orange juice?
Yeah, at times.
How do you feel then?
I get a strange metallic taste.
You do not feel acidity then?
No?
Now, tell me, what do you do whenever you get stomach aches?
I take Alka-Seltzer at times. That gives me a relief from the pain to some extent.
Yeah, that should help with the relief. Do you take any Maalox, Tums, or Mylanta?
No.
Have you ever taken any medication on a consistent basis, such as Advil, aspirin, or Motrin?
I was taking Tylenol usually.
Okay, as I told you earlier, I'm going to examine your feces to investigate whether you have any kind of parasite. Tell me, do you either come from the tropics, or have you ever been traveling to any of the tropical regions or overseas?
Yeah.
Parasites that are found in most of the parts of the world affect the stomach. Besides, I want to check for any occult blood. You have mentioned earlier you haven't seen any changes in your feces, and it's only greener and not darker. Sometimes, if you have a hemorrhage in your stomach, then the digested blood could produce a chemical reaction so that you can have occult blood in your feces. In such cases, we don't see the red color or dark color of the digested blood. Therefore, a diagnosis is essential. Moreover, I would like to diagnose your upper gastrointestinal system through x-rays and contrast. You will be given a thick substance to drink, and then the radiologist would observe how your liver digests the substance and observe your stomach movements. Because I think that your pain comes from your gallbladder and not from your stomach, I will have to do this kind of diagnosis. After a thorough investigation, let me decide whether I should take the x-ray test or an ultrasonic study of your gallbladder. Do not eat any greasy food for now, and also do not have your dinner just before going to bed, because it could produce more acidity. Eat normal food and nothing spicy. I shall get back to you as I receive your medical reports from our lab. Anything else?
With so many medical tests, I'm afraid I have an ulcer.
I too have that kind of doubt. That is why I have suggested all these tests. I need to explain to you that an ulcer or other irritations in your upper intestines cannot be detected by x-ray at times. If the pain continues after having some antibiotics, you may have to go for an endoscopy. An endoscopy is a medical investigation in which a tube will be inserted through your mouth or nose, and then the specialist will observe your stomach, from the small intestines to the large one, and your gullet. Do you need any clarification?
No, doctor, thank you.
Good. Let us meet next week. Goodbye.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
It's quite unfortunate that the patient died. When it comes to pulseless electrical activity, we have less than 3% chance to get them back. He had a lot of comorbidity, so we need to talk to each other about it. The reason why I'm talking to you is that this shouldn't get to us. We're professionals. We have to talk to each other about it. This shouldn't stress us out. It shouldn't bring our confidence level down. We have pastoral care services. If you need to chat to them, you can speak to me as a manager. I can help you with some tips and tricks, because this is not the last arrest you're going to face. There are going to be more. On top of everything, it's a huge learning curve. After every arrest, we need to have such a debrief, so everyone would feel comfortable. I thank everybody for your support. He had a lot of comorbidities, as I said. We need to focus on the things where we need to concentrate. Little bits and pieces. Everything is very important, and a couple of people I want to speak separately about life support. How traumatic it can be, and I saw a few tears. It's all a part of this. Over the last few years, I've lost patients, and I have got some of them back as well. So it's very much an important thing. But I'll speak about it later. But feel free to come and speak to me if you need any help.
Question 26. Now read the question.
The problem of failed teamwork has been identified in both practice and literature. As a nurse manager, I witnessed the power of high-performing teams and also noted the effect that pitfalls in teamwork can have on outcomes. Nursing literature informs us that nursing teamwork has been discussed for many decades, yet is still difficult to achieve. We also know that failures in teamwork can result in poor patient outcomes, patient complications, increased length of stay, and patient mortality. The statement of the problem for this research is that preventable patient safety incidents continue to be expensive on national, organizational, and personal levels. For example, pressure ulcers, a key nurse-sensitive indicator, can result in approximately $50,000 of additional costs to a single hospital stay. In addition, 60,000 patients die as a result of pressure ulcers each year. And pressure ulcers are the second most common litigation claim, second only to wrongful death. Transformational teamwork exists when a transformational leader influences not only individual followers, but also influences the team as a whole to perform optimally, resulting in high-quality outcomes. Transformational teams demonstrate quality teamwork, resulting in high performance and quality outcome indicators, and the work of the team transforms care to a higher level of performance.
Question 27. Now read the question.
We set a comfort goal for 3. What's your pain level at right now, Mrs. Craig? On a scale of 0 to 10, how do you feel?
About a 7.
About a 7. Okay. She's on a liquid diet.
Taking anything for the pain?
She is. She has ordered 0.5 milligrams of Dilaudid IV as needed every 2 hours. And she did receive that about 6:30. I updated the boards, so the next one due, Mrs. Craig, would be about 8:30 this evening. She's also been using splinting, which has helped with the abdominal pain. She's on a clear liquid diet with orders to progress to a regular diet as tolerant. She also has orders to start oral meds as soon as her diet can be advanced, which might help out with some of the pain issues.
So part of my plan of care for you today is going to be making sure that your pain is controlled. You indicated that it was at a 7, and you're not due to have more pain medication until 8:30. And so what I'm going to do is I'm going to go back and I'm going to check to see if there's anything the doctor has ordered for you that we might be able to give you in addition to the Dilaudid that you're already receiving. Many times physicians will order different kinds of pain medications that patients can take concurrently. I'm glad that you're splinting using the pillow to press down when you're coughing or sneezing. That also helps with pain control. Now, another non-pharmaceutical way to control pain, help alleviate it, is actually activity. It might seem counterintuitive, but making sure that your body is moving and that you're using your muscles actively helps control the pain. So if possible, I'd like to get you up this evening. Maybe if nothing else, just walk to the bathroom or maybe walk to the door and then back again. I think that might help your pain, provided it doesn't make it excruciatingly worse, okay? Does that sound like a plan?
Question 28. Now read the question.
We know from all the research we've done on animal behavior and that sort of thing that natural light is huge in terms of keeping the animals calm, less stressed. It's a nice factor for us and our staff when we're inside a building that has good natural light throughout. Usually the treatment area is kind of right in the core of the hospital in the middle. It may have some windows, but not a lot. And that's one of the biggest areas where having natural light is a huge benefit. So how do we get natural light in there? Depending on the design and structure of your building, using clear story windows that are up high, that can, allow the natural light to penetrate down. That's an easy way. Not always possible if you're in a lease space or a tenant improvement space that you're building out. Then you're at the mercy of what building you're stuck with. So other ways to deal with this. Skylights are a great way. You have to have a flat roof usually to be able to do that. Pitched roof you can, but there's products like out there called Solitubes, which are like a skylight, but they are made to work such that they're just a little diffuser up on the rooftop, and they bounce light down through a metallic tube to what often looks like a light just placed in your grid ceiling, but it's the right color temperature light because it is the natural sunlight coming into the space. We've also seen a trend towards people wanting more transparency in the hospital just in terms of their relationship with their clientele. And so using windows through exam rooms, and then that potentially even lead back to treatment. It's kind of a newer concept. Some people love it, some people hate it, but having more windows up front in your exam rooms and potentially passing through to treatment is another way you can get light back into the back of the hospital.
Question 29. Now read the question.
Clopidogrel reduces platelets' ability to form blood clots and is usually used with aspirin. There are several reasons for taking clopidogrel. The commonest is after a coronary artery stent to stop the stent causing a clot. Another is after a heart attack or serious chest pain to prevent a recurrence. One of the risks with aspirin and clopidogrel is a stomach bleed, so some people are also put on an acid-lowering drug called a proton pump inhibitor, a PPI. PPI's names end in azole, like omeprazole. It's the combination of clopidogrel and a PPI that's been questioned in a study following 8,000 people who'd been given clopidogrel after experiencing a heart attack or pre-heart attack chest pain. People taking both clopidogrel and a PPI were a bit more likely to go back into hospital or die from another heart event than those just on clopidogrel. Mind you, people on the combination were older and sicker than those on clopidogrel alone, but even allowing for that, the worst outcomes persisted. PPIs may reduce clopidogrel's antiplatelet effect and therefore increase artery blockages. Now, there are many reasons this study could be wrong, so further work needs to be done. But if you're on the combo and are concerned, have a chat to your GP about it.
Question 30. Now read the question.
So tonight I was talking about how one patient drives the need for research and how the problems that those patients present, however simple, can sometimes be really difficult to solve unless you're working with a team of researchers in the background to develop new ways of doing things. And how by growing trachea in the lab from a group of donor cells, we were able to change a child's life. First of all, the plumbing part of surgery is obviously what we do every day. But to move it on to the next stage, to solve the problems that constantly come to Great Ormond Street, you need research, because it's the new ways of doing things that continually allow us to offer these children some sort of chance, some hope of a better life in the future. And without the close relationship of research and scientists with the doctors and the patients on the ward, you don't make those big steps forward that you need to do.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
It is important to realise that 83% of people who commit suicide or attempt suicide have had contact with a doctor within a year of their death, and up to 66% of people who commit or attempt suicide have had such contact within a month of their death. Therefore, with better prevention techniques, these figures could be reduced. We can divide suicide prevention into three categories, which are primary, secondary, or tertiary. Secondary suicide prevention aims to decrease the likelihood of a suicide attempt in high-risk patients. Tertiary suicide prevention occurs in response to completed suicides and attempts to diminish suicide in a particular geographical area or in a particular age group. I would now like to look at secondary suicide prevention in more detail. Secondary suicide prevention is particularly important, but not always given the attention that it deserves, in part because research into secondary prevention is only just starting to be applied to clinical practice. Now, from a clinical perspective, suicide is often difficult to predict due to its complex nature. The three major risk factors that contribute to suicidal behaviour are biological, psychological, and proximal stresses, which are recent events that can lead to increased suicide risk. Firstly, there are biological risk factors for suicide, which include low blood cholesterol levels, medical or neurological illnesses such as multiple sclerosis, stroke, Huntington disease and epilepsy, cigarette smoking. Secondly, there are psychological risk factors which include a childhood history of physical or sexual abuse, aggressive personality traits, low self-esteem, and poor access to psychiatric treatment. Thirdly, there are proximal stresses, or the recent events that can lead to increased suicide risk, and these include relationship problems with a spouse, partner, or loved one, financial troubles caused by unemployment or large amounts of debt, a family history of suicide, major depression, and drug abuse. The clinical evaluation of the medical and psychiatric history of a patient and of their current state is the crucial and essential element of the suicide assessment process. It is important because it enables the identification of risk factors in order to determine the patient's immediate safety and the best setting for treatment, and also to develop diagnosis and treatment strategies. Psychiatric illness is a major contributing factor to suicide risk, with mood disorders such as major depressive disorder and bipolar disorder being associated with about 60% of suicides. Indeed, psychiatric disorders are diagnosed in more than 90% of completed suicides, and more than 80% of these psychiatric disorders are untreated. Thus, the recognition and treatment of individuals with psychiatric disorders, specifically mood disorders, are essential components of secondary suicide prevention. In addition, the subjective rating of the severity of depression is one of the most powerful predictors of future suicidal acts. Therefore, assessing and managing depression, as well as being aware of the suicide risks in psychologically, medically, and neurologically disordered individuals, is an important aspect of secondary suicide prevention. Consequently, physicians need to be taught to recognize the association between mental disorders and suicide. Additional information about the individual who may be at risk for suicide, such as medical and psychiatric treatment records and toxicology screenings, should also be incorporated into the assessment. Equally importantly, clinicians and other professionals in a position to offer help should not hesitate to ask patients about suicidal ideation because, while it may seem surprising, patients will often talk frankly about their suicidal thoughts and tendencies if given the opportunity. Failure to ask about suicidal ideation may be related to the health professional's discomfort with the topic, lack of time, or lack of skills in this area. Clinicians need to overcome these obstacles to provide appropriate care to their patients. What are the most effective secondary suicide prevention strategies? In a recent systematic review of suicide prevention strategies, Mann, along with other researchers, found evidence of effectiveness in 5 secondary suicide prevention methods, including pharmacological interventions, psychological interventions, follow-up care, reduced access to lethal means, and responsible media reporting of suicide. Antidepressant medications are the most widely used pharmacological interventions in secondary suicide prevention, but studies of their effectiveness in reducing suicide attempts have had mixed results. Among adults younger than 25, the effect of antidepressants seems to be neutral on suicidal behaviour, but it seems to reduce the risk of suicidal behaviour in the elderly. Thus, the relation between antidepressants and suicide needs further studies before this class of drugs can be safely used for the secondary prevention of suicide. In terms of psychological interventions, suicidal patients often benefit from therapies that address the repetition of suicidal thoughts and behaviours, and other factors commonly associated with suicide. Better psychological and pharmacological treatment of depression and alcoholism also appears to decrease suicide rates. Social factors that should be addressed in follow-up treatment include availability and willingness of supports within the family. Support individuals who should be contacted about the suicide risk and follow-up arrangements include general practitioners, private psychiatrists, family and friends. Some interventions, however, such as telephone and psychosocial follow-up, have shown no difference in suicidal ideation when compared with standard aftercare. Many studies show that suicides by particular methods, for example, firearms, domestic gas or pesticides, decrease after the introduction of legal restrictions that reduce access to such means. This reduction in suicide rates is particularly influential in regions where the specific means of restriction correlates with a common method of suicide. For example, in the UK, the reduction of carbon monoxide in domestic gas since 1958 and the reduced availability of analgesics since the mid-1990s have both decreased UK suicide rates. Finally, many studies have exposed a need for a decrease in reporting of suicide and for responsible reporting. Media blackouts in reporting suicide have coincided with a decrease in suicide rates because reports of suicide in the media tend to glamorize suicide for vulnerable individuals. The internet is also of increasing concern, with blogs and chat rooms providing accessible instructions for suicide. For these reasons, guidelines have recently been produced for the responsible reporting of suicide. Despite our increasing knowledge about secondary suicide prevention, there are still many gaps in the research, and looking to the future, thorough evaluations and appropriate treatments of patients with depressive disorders and other psychiatric illnesses should help to improve the efficacy of secondary prevention of suicide. But it is also clear that more research into new approaches for the prevention and treatment of suicidal behaviour remains essential.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
My name's Dr. Neil Strathmore. I'm a cardiologist, and today I'm going to talk about cardiac investigations and try and tell you which test is right for which patient. Patients who present with heart problems present with a variety of symptoms, such as chest pain, shortness of breath, palpitations, syncope and edema. In addition, patients come along because a problem has been picked up by another doctor, such as high blood pressure, a heart murmur, an abnormal lipid profile, or patients present for assessment of cardiac risk to see whether they're likely to have a heart attack. Let's look at the most common cardiac symptom that presents, which is chest pain. Obviously, the first thing to do is to take a careful history of the pain, where it is and how severe it is, and in particular its relationship to exertion. Often patients don't describe this as a pain, but as a pressure. The examination is often not helpful in trying to sort out the cause of chest pain, but one should note the blood pressure and see if there are any cardiac murmurs, because aortic stenosis can also cause chest pain. It's important to note the risk factors. A technique that's very useful for assessing cardiac risk is to use the population data from the Framingham study in the United States to assess 5 and 10-year cardiovascular risk. It's important to remember that women often have an atypical history of pain. So the next step is to do some sort of test to look for the cause of the chest pain. And most of the tests are what are called functional tests, which see the effect of stress or exercise on the heart and see whether that changes something which can give us a diagnosis. The simplest test is an exercise ECG. The patient exercises on a bicycle or a treadmill while an ECG is being recorded. The parameters that are measured are the heart rate and blood pressure, and then changes on the ECG, in particular ST depression. ST depression occurs because ischemia occurs during exercise. This is a relatively simple test and inexpensive. The main problem is that its sensitivity and specificity are probably only of the order of 70 to 80% and seem to be a lot lower in women. Remembering that the test can be inaccurate means that a patient who has a very good story of chest pain that sounds like angina and has multiple risk factors should still be considered to have angina even if the exercise test is negative.
That is the end of Part C. You now have 2 minutes to check your answers.